So let's talk about infectious mononucleosis. So it is an infection. It is a viral infection, and the most common cause is Epstein-Barr virus. So it is the most common cause, and then other uncommon causes include, for example, CMV, which is a cytomegalovirus. So let's come down to the clinical features. So in the clinical features, we will have really like severe fatigue. We can have fatigue, and also there will be fever. So severe fatigue and fever, and there will be also sore throat, and there will be like tonsillitis and pharyngitis, and on the tonsils there will be exudate. Like it can be with or without exudate. So these are the general clinical features, and also it can affect the liver, and it can result in like hepatomegaly or transient hepatomegaly or transient hepatitis. It can also result in splenomegaly, and these are because of the reactive T cells. So when the infectious mononucleosis or the EBV infection occurs, then there are T cells that are activated, and when T cells are activated, they can result in the liver hepatomegaly or transient hepatitis, and the hepatomegaly occur because of the reactive T cells that are activated. And then also there is splenomegaly, and the splenomegaly occurs because of the hyperplasia of the T cells, hyperplasia in the periarterial lymphatic sheath. So the periarterial lymphatic sheath is this area. So now if this is the splenic artery and it is entering the spleen, and this whole thing is the spleen, then we have a white pulp and we have a red pulp. This whole thing is the red pulp, and this is the white pulp. So in the white pulp, there it is an area around the splenic artery, and in the area around the splenic artery immediately is called the periarterial lymphatic sheath. And the periarterial lymphatic sheath, we have a lot of T cells, and when these CD4 positive T cells, these are not helper T cells, these are CD4 positive T cells. So when they are activated in infectious mononucleosis and undergo hyperplasia, then that would result in splenomegaly. So that was the mechanism of how splenomegaly occurs in infectious mononucleosis. Then there's also lymphadenopathy, and remember the lymphadenopathy is commonly it is cervical lymphadenopathy, a posterior cervical lymphadenopathy, but it can be diffuse, so it can involve a lot of the lymph nodes in the body. Like it can involve any lymph node, even the inguinal lymph node, and so infectious mononucleosis can present with diffuse lymphadenopathy, okay? And the reason for that is because when we have like this lymph node, let's say this is the lymph node, and in the lymph node we have the outer area is called the cortex. The outer area is the cortex, and that is where the follicles are present. And the follicles are B cell areas in the lymph node. And then just below it is the area called the paracortex, and the paracortex is where our T cells are present. And CD8 positive T cells, when they are activated in infectious mononucleosis, then the paracortex will kind of enlarge, and that results in lymphadenopathy. So the splenomegaly occurred because of the periarterial lymphatic sheath where the T cell undergo hyperplasia, and the lymphadenopathy occurred because of the T cell hyperplasia that occur in the paracortex. Okay, this is the paracortex, this is the cortex. The cortex is the B cell region, paracortex is the T cell region. So I hope that was clear. Then the third thing, let's talk about the diagnosis. So how do you diagnose it? So the test that that is done is the monospot test. So when you suspect infectious mononucleosis, a monospot test is done, and the monospot test is also called the heterophil antibody test. And so how it works is that the patient's serum, which has anti-EBV antibodies, is mixed with horse or sheep red blood cells, and it will agglutinate the horse or sheep red blood cells. And when that happens, we call that a positive monospot test. So now, in order to differentiate between EBV and CMV is the monospot test. So in CMV, the monospot test will be negative, okay? The monospot is negative in CMV, okay? While in EBV, it is positive, okay? So another thing that is important to know is that in the first week, the monospot can be negative, okay, even in Epstein-Barr virus. So if the patient presents with, like, for example, 3 days of all these fever and fatigue, these symptoms, and you highly suspect that it is infectious mononucleosis, because there is lymphadenopathy, there is tonsillitis, there is fever, fatigue, but you do a monospot test and it comes back negative. So you would think that it is something else, or you may think that it is even CMV. But the 3 days symptoms would kind of make you think that it can still be EBV. So you should repeat the test after, like, for example, after a week, so that the diagnosis is clear. So then another thing that is infectious mononucleosis associated with are the atypical lymphocytes. So these are CD8 positive T cells, and they kind of look like abnormal cells, like really large activated CD4 positive T cells. So they will kind of look like that. If you Google them, you will see a lot of pictures and of atypical lymphocytes. So they kind of look like this, which they have a really abnormal looking cytoplasm, and also there's a really large nucleus. So then how do you manage that? The management is just symptomatic, because there is no antiviral that is used for infectious mononucleosis. But one thing that is really important to know is that that in infectious mononucleosis you should avoid contact sport for about 4 weeks or a month. And the reason for that is because the infectious mononucleosis makes the spleen like really fragile, and contact sport can or may result in a splenic rupture. So just for the point of precaution, it is contact sport is avoided. And another thing, the one complication of infectious mononucleosis or EBV is lymphoma. And so it does not occur in every case, obviously, but it can occur in someone with immune deficiency, for example, HIV. And so, and the reason that this occurs is because infection, the EBV kind of resides in the B cells, and it can reactivate, okay, on immunosuppression. If the patient becomes immunosuppressed somewhere later in his life, then it can be reactivated because it is latent in the B cells. And by the way, do you know which receptors are CD markers the EBV use to enter the B cells or infect the B cells? These are CD21. Okay, so these are the receptors that EBV use to enter the B cells. So this was all about infectious mononucleosis, and hope it was helpful.